Good evening, everybody. Welcome to tonight's webinar. I'm Dr. Peter Hersh. I'm with Dr. Stephen Greenstein and Dr. John Gelles, the three of us being the doctors in the CLAI Center for Keratoconus at the Cornea and Laser Eye Institute. What we wanted to do tonight was go over some updates in corneal crosslinking with an exciting new advance of a clinical trial that we will be starting shortly that may be of interest to a number of you. So let's get going tonight, and we'll save some time when we're through for some questions. Well, first, just look at your cornea. You know, the cornea is what is problematic in keratoconus. Now, the normal cornea is made up of pancakes of collagen. You can see that on the right side here. So this is a cross section of the cornea, and it shows pancakes of collagen that make the superstructure of the cornea. These are like wires on a bridge that make the cornea strong. There are about 250 of these, and they are glued together by biologic sugars or glycosaminoglycans. As you see on the right side of this picture, there are surface epithelial cells on the cornea, and that's what you scratch if you scratch your eye with a contact lens or your finger. Now, keratoconus inherently is a biomechanical problem. It's much like a wobbly bridge that you see on the left side, where the superstructure is not strong enough to maintain the clear lenticule-like corneal dome that gives you good focus. So the cornea is structurally weak and thin. Because of this, there can be a deformation. It's much like having a bulge on a tire which has a thin wall. And when the corneal optics are deformed, not all light is focused to one place. You see here that light is scattered. And this gives you what we call visual static. It's much like having static on your television, which can give you a poor image, poor vision, glare, halo, or multiple images, as you see on the bottom right here. Collagen crosslinking was one of the great innovations in the treatment of keratoconus. The goal of this is to strengthen the weak cornea to prevent further distortion of the corneal surface and to stabilize keratoconus, which is typically a progressive disease. How does crosslinking work? Crosslinking depends on the interaction of riboflavin. Riboflavin is vitamin B2, and it's a photoactive compound. Riboflavin reacts with ultraviolet that it's tuned to its peak absorbance spectrum. When riboflavin absorbs the ultraviolet light, it forms both activated riboflavin and what we call oxygen-free radicals. And this reaction causes crosslinks within the cornea between the collagen fibrils as well as the glycosaminoglycan sugars that make up the corneal superstructure. So it's like adding more wires to a bridge to make the bridge stronger to keep the cornea from further progressing in keratoconus. And as you see here, if you look to the top right, the cornea with keratoconus is quite weak compared to a normal cornea. It's thinner and weaker. When we do crosslinking, you can see here, this is a cornea that's taken with the eye bank. The cornea becomes stronger and stiffer. Collagen crosslinking was first FDA approved in 2016. Indeed, we at the CLAI Center for Keratoconus acted as the medical monitor for this treatment, and it was approved after the first case was done in 2008 and 2016 for the Glaukos KXL system. How does the procedure work? The standard cross-linking procedure begins with removal of those surface epithelial cells. We use a special solution here that loosens the cells. We remove the cells and then apply the riboflavin drops, typically for a half an hour. We then look under magnification to make sure the riboflavin is absorbed through the entire cornea. Once we know that this is the case, you look up at a green bluish light for a total of 30 minutes. The drops are continued, and when we're done, a contact lens Band-Aid is placed. You'll receive an antibiotic and anti-inflammatory drop 4 times a day for about 1 or 2 weeks after the treatment. The contact lens is removed in 4 to 5 days, at which point the epithelium is typically healed. There were 2 important multi-center trials that led to FDA approval, of which we were the medical monitors for each of these. One was for typical keratoconus, and the other was for keratoconus following other types of surgical refractive surgery procedures. So what are the outcomes? First, let's look at this picture. This is a corneal topography map. This is like looking at a mountain range from a satellite. Red is high, blue is low, and green is in between. A normal cornea is completely green. A cornea with keratoconus shows this dome which has thinned and is now pouching out like we saw on that tire, forming the cone. So this is an elevated area. To define the elevated area, we look at the highest point, which we call K max, which means maximum keratometry. Kera means cornea, so this is the maximum height of the cornea. What we found after cross-linking was that the cornea actually improved and was stable after cross-linking. You can see that it improved by 1.6 diopters, diopters being a measurement of the corneal height, whereas the control group that was not treated worsened. And this was a substantial difference. Now, there is a time course in the healing such that your vision might actually get a little bit worse initially and then improves afterwards. We also found that corneal topography improved. This is one case beforehand, and afterwards you see the red is less red and the cornea is less steep. And we also found that ocular aberrations or visual static improved in general after the cross-linking procedure. Similarly, if we look at vision, higher is better when it comes to visual acuity. And in general, patients improve by 1 line on the chart. So if you're looking at the normal visual acuity chart, most patients on average improve 1 line. We also looked at questionnaires that people filled out, looking at their subjective visual function. We found that problems such as night driving, glare, halo, starburst around light, all improved on average to a small extent. It's important to know, however, that the goal of cross-linking is not to improve your vision. It's not to improve your corneal shape. Rather, it is to keep the cornea stable and to prevent progression of keratoconus, which is a progressive problem. Looking at safety, there are rare cases of infection or scarring. We only found 1 case of infection in 700 eyes that were treated in the study. But we do notice during the healing process an associated evolution of a corneal haze. It's just a very fine haze that we see under magnification when we examine you, but it is something that you can notice early on. So early on, you might see that your vision is a little hazy for the first month or so. These are cross-sectional views. Beforehand, a clear cornea, a little bit of haze at 1 month, which stabilizes at 3 months, and then clears afterwards. It's really wound healing after the cross-linking procedure that causes the haze and the resolution of the haze. In the preoperative time course, where we find that it may be a little worse in your vision early on and then improving later on. And a lot of this is secondary to healing of those surface cells. But Dr. Greenstein is going to discuss the transepithelial procedure, which hopes to give you a quicker healing. And this is what we're going to be looking at in the clinical trial in which we are principal investigators. We did a study looking at who does well and who does poorly with cross-linking. We looked at 104 of our own patients and looked at their corneal elevations and best vision afterwards. When we looked at the corneal topography, that is, how red was the cornea afterwards, we found that on average, people got better by 1.6 diopters. Indeed, 31% of patients got substantially better, but there were 3.5% of patients who continued to worsen. So looking at this method of cross-linking, about 95% of patients are stabilized by the cross-linking procedure. About 3 to 5% of patients may need to undergo the procedure again. Indeed, we found that patients who had worse keratoconus initially tended to improve their topography more so. This doesn't mean the other patients were unstable, but patients who had worse KC did tend to get even better. Similarly, we found with looking at vision, there was an average of 1 line improvement, but indeed 22% of people got substantially better. They got better by 2 or more lines. But again, 3% of people did lose a little bit of vision. So we found it's very important to treat each patient as an individual, looking at our individual goals of stabilizing the keratoconus process, making sure that you don't lose vision, and improving your corneal surface. Now, we've been following these patients for 10 years now. I did that first case back in 2008 in our center. Actually, we were the second to do it. The first was done down at Emory in Atlanta. But we've been following patients now for over 10 years. This was just our center. We looked at 30 eyes of 16 patients to see if there was indeed any change over time. If you look here, on the left are patients with both ectasia and keratoconus. And what we found that there were 76 or 77% of all these patients were stable. However, if we look on the right side, we find that 87% of patients with keratoconus are stable after the procedure. That's long-term, over 10 years. And indeed, 86% of all patients have stable vision, and 100% of keratoconus patients had stable vision over the 10-year period. So results are quite good and quite long-lasting but it does not mean that you can stop seeing your doctor. You should be seen certainly on a yearly basis to make sure things remain stable. I'm now going to turn over the podium to Dr. Greenstein as we turn to some new innovations in cross-linking, as well as our upcoming clinical trial. Dr. Greenstein.
Thank you, Dr. Hersh. So now that we reviewed cross-linking and the standard epithelial off cross-linking, which as we saw with Dr. Hersh's presentation, we now have evidence out to 10 years that the stability of cross-linking is generally very good. There are some new approaches to cross-linking which may make the procedure have a little bit of a quicker recovery for patients. And one of those approaches is transepithelial or Epion crosslinking. So as Dr. Hersh talked about in his presentation, there are multiple layers of the cornea. The stroma, which is the collagen lamellae, the central portion of the cornea, is where we want the cross-linking to take effect. It's where we want the stiffening to happen. On top of the stroma, there's an epithelial layer, which is the surface layer of the cornea, very similar to your skin, which acts as a barrier for penetration into the cornea. And this barrier prevents the riboflavin from absorbing into the stroma, and it also prevents the light from reaching the stroma and creating the cross-linking effect. But if we can penetrate the epithelial layer, if we can penetrate the surface layer with the drops and the light, this can offer several advantages. One of the advantages is the potential for a faster recovery without needing the epithelial layer to heal. Patients can recover potentially within maybe 24 to 48 hours of having the procedure done. And also without wound healing, without the necessity of the surface layer to heal, there's less chance for infection and inflammation and potentially even scarring. However, the epithelial layer, as I said, is a barrier. And so there are certain disadvantages or potential challenges to the cross-linking treatment if we leave the epithelium intact. There's a challenge to getting the riboflavin through the epithelial layer. There's the challenge of getting the light through the epithelial layer. Cross-linking depends on two pathways. It depends on riboflavin, but it also depends on oxygen to create the cross-linking effect once it is stimulated by the UV light. And there is also decreased oxygen diffusion when the epithelial layer is intact. And finally, there may be some elements of the wound healing process that actually facilitate some of the cross-linking effect, and we may be losing that with the transepithelial approach. Now, there are certain modifications that have been made to cross-linking, which has improved the epithelial on cross-linking and has allowed us to offer this procedure to patients. One of those changes was to the formulation of the riboflavin drops. So traditionally in FDA approved off cross-linking, the main riboflavin drop which is used is mixed with dextran. In the current formulations of riboflavin, which are generally used in the epithelial on approach, either a methylcellulose form or a saline form of riboflavin is used, which keeps the cornea from thinning, it keeps the cornea from dehydrating, which can be helpful with the cross-linking effect. We also are able to increase the concentration of riboflavin, and with an increased concentration of riboflavin, we can penetrate into the corneal stroma more effectively. And we add certain other elements to the riboflavin formulations, which can increase the permeability of the epithelium, of the riboflavin through the epithelium, so that we can get more soaking of the riboflavin before administering the UV light. As I just discussed, there's really two pathways that promote crosslinking. The main pathway that we're all used to talking about is the riboflavin pathway, which is that we administer the riboflavin drops to the cornea. And when those riboflavin drops mix or are activated by the UV light, this creates the crosslinking effect. But there is a separate pathway which depends on oxygen, which can be activated with the UV light to also create a crosslinking effect. The problem in standard epithelial off crosslinking is that most of the oxygen is used up almost immediately in the procedure. And so we depend almost exclusively on the riboflavin pathway to create the crosslinking effect. But certain modifications to the light, such as pulsing the light, having it go on and off with 1 second on, 1 second off, can actually allow for reoxygenation of the cornea, better oxygen diffusion, and potentially an increased crosslinking effect. In addition, there are certain modifications which have been looked at which can increase oxygen exposure and oxygen availability to the cornea, which can also promote crosslinking. And one of those that has been most recently investigated is oxygen goggles, which can be worn during the treatment to enhance the oxygenation for crosslinking. We began doing transepithelial crosslinking or Epion crosslinking as early as 2013 and began to report on our results in 2014. And in our first cohort of patients, we looked at 82 eyes with 1 year follow-up after Epion crosslinking. This was done in a single center. This was done at our center here under a physician IND. And what we found was that the maximum keratometry, which again is the steepest portion of the cornea, flattened by just under a half a diopter, which is the measure of curvature, about 1 year after the crosslinking treatment. This was a statistically significant flattening, but less than we were used to seeing with the epithelial off approach. What you can see down below is that when we looked at individual eyes, most eyes do remain stable after Epion crosslinking. So most eyes either had no change or did have some flattening effect 1 year after crosslinking. So about 85% of eyes remain stable or flattened 1 year after Epion crosslinking. And the primary goal of crosslinking is stability. We did see some small changes in uncorrected and corrected vision after crosslinking. There was just under a line of uncorrected improvement, which was statistically significant. And there was just a few letters of improvement of corrected vision, which did not turn out to be statistically significant. So overall, what we saw in our early results of Epion crosslinking is that there does appear to be stability after the treatment. There is a small amount of flattening after the treatment, and there is some change and improvement in visual acuity after Epion crosslinking. But it does appear that those changes are slightly less robust than the Epi-off treatment itself. Now we have the opportunity to introduce a new study, which we're very excited to have been selected as one of the 4 US sites available to receive the NXL, which is the new generation of transepithelial crosslinking. So this is going to be an Epion crosslinking. The epithelium will remain intact, which offers us the advantages that we discussed. But the difference with the NXL treatment is there's going to be a new delivery method of the UV light to activate the riboflavin and the oxygen to create the cross-linking. And this is going to be done with a laser diode treatment. So there are going to be small spots of laser treatment that will be administered in a spiral pattern. And these small spots of laser will then activate the riboflavin, creating cross-linking. And this may allow us to create more cross-linking, but also really refine our cross-linking, because right now, current cross-linking is done with a diffuse light. So the light shines all around the 9 millimeters of the cornea. This allows us with a laser to deliver a precise amount of light to each spot of the cornea individually and make sure that an equal treatment is given to the entire cornea in the treatment zone. So as I said, we're excited to be one of 4 sites that were chosen in the US to participate in the NXL study. And this study will be offered to patients at no cost. There will be no cost for the screening, the treatment, and the follow-up. So who can be included in this study? So first, you must be between the ages of 18 and 55 to be considered for the NXL study. You must have keratoconus. Patients who have had previous corneal surgery, such as LASIK and PRK, and developed their keratoconus afterwards, developed what we call a laser vision ectasia, cannot be included in the NXL study. And then there are certain parameters from your corneal maps and your vision that you have to meet the criteria. So the steepest portion of the cornea has to be greater than 47 diopters, and your corrected vision has to be worse than 20/20. We will check those parameters in your screening visit to determine if you are a candidate for the treatment. Now, it's important to note that contact lens wearers do need to leave their contact lenses out for a week prior to the screening visit. If you have your contact lenses in for any shorter than a week before the screening visit, this may require one additional visit before your treatment to perform some of the analyses that are needed. And of course, to participate in this trial, you must be willing to come back for all of the follow-up visits, which we'll review in just a minute. So what are some of the exclusion criteria? As I mentioned, you can't have had previous corneal surgery. So this includes previous LASIK, previous PRK, or previous SMILE. This also includes previous cross-linking. If you have received cross-linking treatment in the past, you're not a candidate for the NXL study. Intacs or any corneal inlay would also exclude you from the study. In addition, if you have a history of intraocular surgery, such as cataract surgery, you cannot be included. We will measure your corneal thickness when you come in for the screening. Corneas have to be thicker than 400 microns to be enrolled in the study. And we'll review some of the other exclusion criteria when you come in for the screening. So how does the NXL procedure work? So similar to the standard cross-linking procedure, there is a pre-soak period. There's a period of time where drops will be administered before the laser light is turned on. In this case, the epithelium will not be removed, so that's the Epion approach. And you'll have 2 separate formulations of the riboflavin drops that will be administered. For 4 minutes, riboflavin will be administered with the BAC solution, which can open up the epithelium and increase the permeability. And then for 6 minutes, riboflavin will be administered to soak the stroma of the cornea. Then you will be broken into one of 4 groups. 3 of the groups will receive the NXL treatment, and 1 group will not receive any treatment. This is the Sham group. The groups will receive a slightly different dosage of treatment. So 1 group will receive treatment of 10 milliwatts over the course of just under 12 minutes. The second group, 15 milliwatts just over 11 minutes, and then 15 milliwatts just under 17 minutes. So the total procedure is significantly shorter than standard crosslinking and any of our previous Epion procedures, both for the pre-soak and for the treatment itself. The final group, which will not receive the NXL treatment, will be required to stay under the light, which will not be turned on, for just under 12 minutes. If you are in the Sham group, if you do not receive NXL crosslinking, once you are exited from the study at 6 months, you will be allowed to cross over and receive crosslinking. In this case, you will not receive the NXL treatment. You will receive standard crosslinking treatment at 6 months, also at no cost. So what is the visit schedule? So as I mentioned, there will be a screenings visit, which must be within 45 days of your treatment. There may be an additional visit if you are required to have measurements taken with your contact lens removed. You will be scheduled for a treatment visit in our office, and then you will need to follow up the day after treatment, the week after treatment, at 1 month, 3 months, 6 months, and 1 year. Again, the Sham group will cross over to receive regular standard crosslinking at 6 months. These are going to be done in windows, so there will be a window of time that you can come back, which will fit into each of these post-op visits, but you will be required to come back for all of these visits in this study. So we are really excited to be entering this new era of crosslinking, this new era of a laser crosslinking. We think it's a big step forward for crosslinking treatment in keratoconus, and we are very excited to be able to offer it to our patients here at the Corneal Laser Eye Institute. So if there are any questions, we'd be happy to answer them now.
Hi, Dr. Greenstein, it's Stacy. There are a few patient questions that I wanted to ask you. So this one patient had asked if they've had CXL before in one eye, can they still participate in the other eye?
Yes, so if you've had CXL in one eye, and you meet the criteria in your non-treated eye, you can participate in the NXL study. One thing you cannot do is participate in 2 studies simultaneously. So if you have just received study crosslinking in one eye, then you would have to wait to be finished with one study to enter the NXL. But if you've received general crosslinking in one eye, you would qualify for this study.
All right, thank you. If a patient has keratoconus in both eyes, will both eyes receive the same treatment under the study?
No, only the one eye is going to be treated under the study. The other eye would have to have standard cross-linking using the FDA-approved approach, which would be the standard cross-linking without the with the epithelium removed. The treatment that we do commonly in the FDA-approved protocol.
Okay, and then if I wanted to have cross-linking in my other eye, even though that's not in the study, could I do that while my first eye is in the study? Does
yes,
that make sense?
Yes.
Okay.
Yes, as long as you're receiving standard cross-linking, you can have that done in the other eye.
Okay. So I have a patient that is from out of town and may not be able to make all the follow-up visits. Will that be a problem?
Yes, for this study, we do need patients to be available for all of the follow-up visits.
And there are large windows as we go on. Certainly, we need to see very critically the day after and a few days after that to make sure everything is safely healing. But as time goes on, there are larger windows which should make traveling easier.
Great, thank you. So somebody had asked if the procedure is free, which we know that you had said it is. There is no charge for the procedure. There's no charge for your post-op visits throughout the year. Do you have anything to add to that?
No, as long as you're a candidate and you come for your visits, the procedure will be done at no cost.
Okay. To know if I'm a candidate, can I send you records to review, or do I have to come in for an appointment?
So you can definitely send records to see if there's anything that might immediately exclude you from the study. But no matter what, you will have to come in for an official screening visit to actually be enrolled in the study. We cannot.
Right, so we can give you an idea by looking at your records if you are likely a candidate or not.
Okay, great. Now, speaking of,
maybe Dr. Yellies can comment on resumption of contact lens wear in patients who are in the study. Clearly, we have to keep the lenses out before the visits to make sure the cornea is of normal shape. But Dr. Yellies maybe comment on using contact lenses afterwards, especially in the transepithelial procedure.
In between the visits, wearing the lens is not going to be a problem. Generally, with transepithelial corneal collagen crosslinking, we can resume contact lens wear within about 2 weeks after the procedure. Now, the one thing that's very important to note in this study is that you will need to discontinue your contact lens wear temporarily for the purposes of the study visits so that we can get uncontact lens affected measurements.
Right. I know that patients often ask the question, after cross-linking, will they need to change their style of contact lens?
Totally dependent on, kind of where you're starting. Most of these individuals, though, the changes that cross-linking will cause to a cornea are very, very minute and typically do not require large changes to the parameters of your contact lens or changes to the type of contact lens that you're in, such as going from a scleral lens to a soft lens or something.
great, thanks, Dr. Gellies. For candidacy, I know that you guys had mentioned that you're not a candidate if you've had, I guess, other surgeries or other conditions. What about glaucoma? If you have glaucoma and pigment disbursement, does that disqualify you?
I do not believe it would. We'd have to examine you and make sure there's not visual loss because of the glaucoma. So it really would be on a case-by-case basis. But pigment dispersion would not be a contraindication.
Okay, great. That about wraps up the questions that I have.
Great. Well, we're looking forward to seeing patients and screening people for this new NXL crosslinking, and stay tuned for future webinars where we'll also discuss some other new breakthroughs in crosslinking and keratoconus treatment.
Right, there are a lot of new things, as we know. the initial breakthrough in the treatment with keratoconus really was corneal crosslinking. It's the one thing that can keep the cornea stable and avoid progression to things like corneal transplants, which now are very uncommon after crosslinking. And then what followed were developments of new kinds of contact lenses. So there are a lot of new specialty contact lenses that really can be conformed in a very custom manner to give you even better vision. This was followed by work that we have been doing in topography guided laser treatments. So there's some select patients who have had crosslinking who can have the cornea smoothed and achieve a better quality of vision and better corneal optics. And there are brand new procedures that we are starting that we've been studying for 6 years in our institute, which we're very excited about, called corneal tissue addition for keratoconus, which is an exciting new method that we hope is going to help a lot of patients. So I don't know if any of the doctors have any other comments. Myself, thank you all for attending tonight. And we look forward to either seeing you or seeing you on future webinars.
Have a good night.